Thank you. Good morning. It is a great honor to be here, and I would like to thank the meeting organizer for the invitation. So my topic will be on the precision health. And first, I would like to mention a little bit about current status of chronic disease or cancer. Chronic disease are major health concerns at the world. It is estimated that chronic diseases were responsible for 71% of deaths globally in 2015, primarily from cancer, cardiovascular disease, diabetes. In 2018, the incidence of cancer was 18.1 million, and by 2025, the number of new cancer cases will rise to 20 million. For example, on average, 7 people were diagnosed with cancer every minute in China. The major challenges in cancer prevention and treatment are it is difficult to prevent, and also usually it is very late in discovery of cancer, and also it is very complicated to treat, and a lack of standardized guidelines. And in terms of the large-scale screening tests for cancer, and it has a high false positive rate, and also currently it lacks high-quality clinical big data that support pre-cancer or clinical outcome research, and also currently it lacks of effective risk prediction models. And the big challenges or the central issue in overcoming cancer is its heterogeneity. The existence of heterogeneity is due to many factors, including the genes we inherit from each of our parents, and the cancer's somatic mutations, and also the microbial cell genes, and the environment, including the internal and the external environment of each person are different. And heterogeneity is manifested in many aspects. For example, there is a wide variation in reactions to environmental exposures, and also there is a variation in susceptibility to risk of cancer, and also response to treatment can be varied person by person. Therefore, the effects on clinical outcome, the results could be different. Therefore, it requires precision medicine or precision health. A vital component of precision health is prediction. From the patient's perspective, they want to know, what is my risk of cancer? And also, what screening options are the best for me? And also, if a person has been found that he is at high risk for cancer, and he might want to know, what can I do to lower my risk? And also, if a person is unfortunately diagnosed with cancer, he might want to know what is the best treatment options for me. For example, if their cancer is predicted to be non-aggressive, and they want to know, do they need intensive treatment that comes with potentially increased toxicity? So risk prediction have applications across the cancer continuum, from healthy people before cancer develops all the way to survivorship after cancer development, where there are opportunities to predict and identify targets for prevention, intervention, and therapy. The results of the prediction can be used in clinical care to manage this risk across the cancer continuum, including behavior changes, prevention, intervention, evidence-based screening, and personalized therapy, and risk-stratified follow-up care. What we wanted to do is we want to bridge the gap between research discovery and their translation into clinical and public health applications to benefit not only the cancer patients, but also individuals at elevated risk for cancer and the general population. So the precision health requires a transdisciplinary collaborative effort. It mainly involves 5 themes. In theme 1, we develop and expand variable cohorts, collect multi-layer information for studying cancer risk and outcomes. And in theme 2, the focus is on modifiable risk factors. And the modifiable risk factors is like your lifestyle and also your whether you do the exercise or what you are eating. And in theme 3, the focus is on identifying biomarkers in the laboratory for risk stratification across the cancer continuum. And in theme 4, we take a comprehensive computational approach to utilize the information from themes 1, 2, 3, and to develop risk prediction models. And individuals with different risk may make different lifestyle choices or decisions about possible preventive interventions to reduce the risk or best treatment to improve clinical outcomes. Therefore, theme 5 is to translate the discovery into the real-world applications. So the collaboration involves not only academic institutions, but also the biotech and other industry, and also the government. So in theme 1 is established research infrastructure, or the big data, or the biobank. And collect the high quality big data is the key to precision health. So for theme 1, we need to build standardized database and biobanks, integrating information collected at individual, community, and genetic levels, and then apply data mining and machine learning approaches to identify biomarkers, modifiable risk factors, and develop prediction models with the aims of precision prediction, prevention, and treatment. And next, I will briefly discuss a few cohorts, since depend on what questions you want to ask and whether you want to ask the questions about cancer etiology or the prognosis or the clinical outcome. And then you will need to collect the different or to utilize the different cohorts. So the first cohort I want to mention is a large prospective cohort from Taiwan, and it has over 500,000 individuals undergoing health screening in Taiwan, and it is called the Mg Health Screening Cohort, or the Mg Cohort. And this cohort was initiated by late Chairman Cao from Mg Group in Taiwan, and I have been working on this cohort for over 12 years now. And this cohort started since 1994. The uniqueness of the cohort is that it has not only has the questionnaire data, but also has the clinical and blood tests and other health screening examinations. And this is one of the best cohorts on the world for research on chronic disease and cancer etiology, mortality, and lifespan. And the second cohort I want to mention is the pre-malignant lesion patient cohort. And you know, cancer is often detected and treated at an advanced stage with disappointing results. In order to avoid this outcome, the better strategy is to detect the cancer as it develops, at its earliest stage, and this allows for preventive intervention to stop or even reverse the detectable process before cancer develops. Therefore, we developed a pre-malignant genome atlas program to identify the molecular changes that predict progression from colorectal adenoma to cancer. And we have been recruiting patients when they came to MD Anderson for colorectal cancer screening, and we collected the colorectal tissue, stool samples, blood sample, and in-person interview questionnaire data. And the third cohort I want to mention is the MD Anderson cancer patients and survivors cohort that I initiated 10 years ago, including over 200,000 newly diagnosed cancer patients. We recruited the patients using front door consent. When they registered as a patient at MD Anderson, we collected the blood specimens named as blood sample research resource, and the questionnaire data named as PHTB, and it's also the full name is patient history database. And then we abstract the pathology and the clinical data from institutional electronic health record, and then linked with medical testing results in laboratory medicine and tumor registry data. It provides a rich resource for a panel of clinical outcome research to advance precision medicine. And this cohort can be utilized to identify molecular markers and create prediction models for risk stratification, response assessment, and treatment decision. And in the MD Anderson cancer patient cohort and the PHDB, patient history database, is one of the major components of the MD Anderson cancer patients and survival cohort that was launched in 1999 with the goal of systemically collect and archive risk factor and clinical data on each newly registered patients at MD Anderson. It serves as a clinical tool for the clinician to complete the primary medical evaluation. It also provides data for research purposes. It identifies high-risk patient candidates for intervention programs such as tobacco treatment program. It also serves as a rich resource for conducting translational research. Therefore, and also the PHDB collects core risk factor data with a total 12 modules, and it takes about 30 to 45 minutes to collect. For example, it collects information on history of tobacco consumption, alcohol consumption, and also the person's cancer history, and also collects the demographic information, past medical history information, and symptoms, and also its the person's occupation, and also we review his system or her system, and then we also collect the information on substance use, exposure, family history, and his quality of life data. And with this big data, and we hope to break island to resolve key issues related to 3 levels of prevention, such as cancer and chronic disease prevention, risk stratification, and precision treatment through application of the big data methods, and also evidence-based medicine and artificial intelligence. And one of the big area of research with these cohorts is the identification of modifiable risk factors. And this will allow us to make informed evidence-based recommendations on lifestyle changes to reduce risk. And for example, energy balance is become a major concern with the lack of exercise and also the obesity epidemic across the nation and the world. And we have studied the minimum amount of physical activity that is needed to reduce mortality and prolong life using Mg Cohort. And the red line here shows the mortality reductions with each increase in number of minutes of physical activity. And you can see, and our results found that just 15 minutes of physical activity per day, it can result in a 14% reduction in mortality and a 3-year increase in lifespan. And also, each additional 15 minutes has an additional 4% reduction. And this is for all intensity, like the exercise intensities combined. But you can see how those who have 15 minutes of vigorous activity have an even more dramatic reduction in mortality. And in another study, and we studied the chronic disease or the chronic disease biomarkers. And then we weighted the risk of 8 chronic disease or markers, the risk for cancer, and then to create a risk score, and one for a risk of cancer incidence, and another for cancer mortality. And as shown in the green lines in these 2 figures, chronic disease risk scores were positively associated with cancer incidence and mortality in a dose-response manner. We also assessed whether physical activity could reduce the risk of cancer incidence or mortality, and associated with the chronic disease and the biomarker. As shown in the red line and the blue lines, physical activity attenuated the increased risk of cancer incidence and mortality, and it attenuated the risk by approximately 40%. And with smoking and low physical activity being 2 of the major risk factors for non-communicable disease around the globe, and my colleagues and I propose to apply empower-like measures. Empower approach were introduced by WHO to assist in reducing smoking harms. It slow monitor behavior, protect the people from smoke, offer treatment, warn of harms, enforce the law, and raise the price of tobacco. And so WHO induced the Empower to reduce the harm from smoking. And we proposed using the Empower-like measure to address the burden of physical inactivity. Sorry. In addition to physical inactivity, the obesity epidemic is another major concern. There is strong evidence that excess body weight increases the risk of developing cancer in the global population. Among cancer patients, sorry. Current oncology guidelines recommend that they should keep a normal weight, and this recommendation is largely extrapolated from data on risk of developing cancer, and using data from big data from Ambient cancer patients and survivor cohorts. Surprisingly, we found that patients, compared to patients of normal weight, patients who were overweight or obese had a 15% and 17% reduced risk of death. And the underweight patients had a 40% increased risk of death. In order to pinpoint the exact level of BMI that is associated with the obese-based survival, we analyzed the BMI as a continuous variable in spline analysis. We found a U-shaped association, and patients with lowest BMI has the highest risk of death. The risk started to decrease as BMI increased, and the lowest risk was observed for BMI around 30. Then the risk started to increase as BMI values increase. And I would like to bring to your attention, and 25 is the cutoff points to define overweight, and 30 is the cutoff points to define obese. And therefore here you see actually the patient's obese and has a better survival. And also overweight and obese BMI were associated with longer life expectancy, while underweight BMI was associated with the short life expectancy. For example, among men, overweight had up to 4.5 years longer life expectancy, and obese patients had up to about 6 years longer life expectancy. And these results suggest that the weight management recommendation should not be the same for cancer patients as for the general population, emphasize the importance of precision prevention for individuals. Another interesting and detectable topic is related to cholesterol. High cholesterol and either low density lipoprotein cholesterol or total cholesterol has been recognized as the cardiovascular disease risk factor, leading to the current cholesterol treatment guidelines that emphasize the lower the better. And using data from the Mg cohort, we found that the lower LDL cholesterol levels were associated with high risk of mortality for all-cause injury, all-cause death, injury, cancer, hemorrhagic stroke, and liver cirrhosis. And on the other hand, high LDL cholesterol were associated with high risk of death from coronary heart disease. And therefore you can see the high cholesterol levels is associated with coronary heart disease. However, the lower level cholesterol was associated with increased risk for other conditions. And this slide shows the loss of life expectancy attributable to low and high cholesterol levels. As we can see, lower LDL-C levels, which are indicated by the blue bar, were associated with great loss of life expectancy than high LDL cholesterol levels, which are indicated by the orange bar. And this is consistent for each age group. The difference for total cholesterol is even more evident. And again, these results suggest that the current recommendation to maintain the lowest possible cholesterol level may not improve life expectancy and may even cause harms. And the current recommendations on cholesterol should be tailored to individuals under different conditions. For example, whether for those with high or versus lower baseline cholesterol. And therefore, again, we need to emphasize the importance of precision medicine or precision health. And also using the big data and and the biospecimen. And another research focus of research is the discovery, development, and translation of biomarkers for risk stratification across the cancer continuum. And for example, to identify biomarkers for predicting obesity or smoking addiction, and also to identify candidates for screening, response, and progression for early stage disease and response toxicity survival for late stage patients. And we have created advanced genetic, phenotypic, and omic platforms, which will help to identify blood-based biomarkers to accurately predict risk and detect the disease early. And for example, we have identified molecular markers of progression from colorectal adenoma to adenocarcinoma. And we utilize the whole exome sequencing and targeted sequencing. And totally, we have studied 149 adenoma samples and then paired blood samples. And the identified somatic mutations then were compared with those in colorectal cancer. And these data are from TCGA. We found that conventional adenoma and cell-serrated adenoma had similar mutation frequency, but the genes involved substantially different. And we found both novel and non-colorectal cancer related mutations with driver patterns were observed in adenoma. And some genes are unique genes, and some genes are shared by both histology type. And interestingly, we found no APC mutations was discovered in cell-serrated adenoma. Therefore, it indicates that cell-serrated adenoma, the carcinoma, adenoma developed to colorectal cancer, it might through a different biology mechanisms. And then we combined the whole exome sequencing and targeted screening, and then we found additional driver genes in colorectal cancer, and they are carriers FBXW7 and SOX9. And this figure shows we found 5 genes. We found non-silent mutations. The frequency in these 5 genes had a statistically significant consistent trend in non-advanced and advanced conventional adenomas and colorectal cancer tissues after adjusting for multiple comparisons. And also differences in the composition of the non-silent mutations were also observed. For example, the p53 mutations in conventional adenoma were exclusive missense, while a quarter of mutations in colorectal cancer were truncating mutations. Then we, in order to identify what are the most important genes and that could significantly differentiate between adenomas and colorectal cancer. And then we performed the permutation random forest and identified 20 genes with non-silent mutations. A 20 gene panel and can distinguish colorectal adenoma from adenocarcinomas with an area under curve, the AUC, reached to 94%, and the error rate based on these genes was 14.4%. Therefore, these genes and these tools could be utilized to potentially for colorectal cancer early detection. And next, and we can use the data and also using the big data and the biospecimens and generate the risk factors and the biomarkers. And then we can utilize all these informations and to build up integrative risk prediction models. And for the risk prediction models, the first I want to show you a few examples. The first application of risk prediction model is to assess personal cancer risk. And these tools can help with identification of high-risk individuals for risk reduction and intervention. And next, I want to show you an example of risk prediction model for hepatocellular carcinoma. And this model is personalized. So basically, using this model, we can, based on the person's, the lifestyle information and screening informations and the biomarkers and other information. So basically, we can predict the person's, the personalized risk in next 1 year, 2 years, 3 years, or 5 years, and 10 years. And we utilize the data and routinely collect in a typical clinical office visit. And we want to create a model that is convenient for clinical use. Therefore, we use the Mg health screening cohort. And again, our purpose is to provide a simple, efficient, and it could be widely available widely used to identify and quantify cancer risk in the average risk population. And in this study, a total of over 428,000 individuals from Mg cohort were included in this analysis, and with a follow-up of an average of 8.5 years. And a total of 1,668 cases were identified at the end of the follow-up period. And from there, 2 subsets were analyzed, and those one is without HCV test and one is with the HCV test. And then when we do the analysis, we divided the subjects with the training and the validation sets. And then we created a series of models that incorporated various predictors of liver cancer. The prediction power of each model is demonstrated by a ROC curve. And then for the initial health history curve, the area on the curve, basically the prediction power is about 8%, is at 0.807. Which is already a very strong model. And however, this model improves dramatically to 90% with just 2 serum markers, just the ALT and AST. And then the addition of the HBV status improved the model to 92%. And this model are in the sub-cohort without the HCV test. And for the sub-cohort with HCV test, and almost identical models were generated. Again, the combined model had an area on the curve of over 93%, because transaminase levels can be easily tested in routine clinical checkups. This model has a great potential to be translated into clinical use and have public health benefits. And then we use the final risk prediction model to calculate probability of developing liver cancer in 5 and in 10 years. We used 6 hypothetical examples, and let's compare 2 similar individuals with regards to, the similar individuals and they're similar in terms of age, gender, transaminase levels, and AFP, and also both are positive for HBV and HCV tests. And the two examples are on the left and the left columns. And the two individuals, all the other factors are the same, and the difference are modifiable risk factor. And for example, whether they're smoking, and whether they're drinking, and whether they're doing exercise, or whether their diabetes are well managed. And we found the hypothetical individuals on the right did not smoke, did not drink, did not have diabetes, and was physically active. He do exercise. And his 5-year risk was drastically, was decreased dramatically, and decreased by over 30%, by over 30%. And his 10 years risk was nearly 25% less. And this is similar for these two cases, and for the other two cases. Therefore, risk prediction models could be utilized to encourage people to have a healthy lifestyle for risk reduction. And another example I want to show is personalized risk prediction models can also be used to refine evidence-based screening measures. And tools are needed in this area to target those at highest risk for screening options, and also to reduce false positive findings and enable early detection to reduce mortality. So I will use our lung cancer risk prediction model as an example. For lung cancer, low-dose CT screening can reduce mortality by 20% based on U.S.'s National Lung Screening Test, the big clinical trial results. However, there is need for better prediction models to identify high-risk individuals beyond heavy smokers for low-dose CT screening because of the high false positive rate. Additionally, light and never smokers account for a large portion of lung cancer, and a subset of them could have risk as high as heavy smokers, and therefore are candidates for low-dose CT screening. We have developed a prediction models from Mg Cohort, and not only for heavy smokers, but also first time for light and never smokers to differentiate the individual's risk with dramatic difference. And the overall model we created had a prediction power of 85%, which is a significant improvement over existing models of 65 to 70%. For example, in the heavy smoking group model, the 5-year lung cancer absolute risk ranged from 0.16% to 3.53%, and similar 10 years lung cancer absolute risk and ranged from 0.42% to 8.82%, a risk difference of over 20-fold. In other words, we can identify the highest risk individuals in the heavy smoking group for low-dose CT screening, and this will substantially reduce the false positive rate. A similar separation of risk profile was observed for the never smoking, for the never smokes group, and with a 5-year lung cancer absolute risk ranging 0.11% to 11.56%, and 10 years lung cancer absolute risk from 0.26% to 24.86%, a risk difference of nearly 100-fold. And we have been the first ones to generate lung cancer risk prediction models for never smokers, and this is due to our identification of novel biomarkers and incorporating of lung function tests as predictors. And using criteria of above 1% predicted lung cancer risk in 5 years from our models. And then we found 29.9% heavy smokers and 1% light smokers and 0.7% never smokers would be candidates for low-dose CT screening. Please be reminded that 80% of the general population in US is never smokers. Therefore, even 0.7% never smokers, and the population is still big. And finally, another model I want to show is some examples of models for helping clinical decision makings to help the patients or help the clinician and in terms of clinical decision. And here is a model and the prediction model for accurate radiation toxicity for non-small cell lung cancer patients after their radiotherapy. Since radiation toxicity are relevant to inflammation status, and we created a chip on inflammation genes, the SNPs, and then we generated a risk score based on genetic variation within inflammation-related genes, and then with the discovery and validation phases. And then the final validated polygenetic risk scores, including 10 SNPs for esophagitis. And the esophagitis and pneumonitis are the two major toxicities caused by the radiotherapy associated events. And the polygenetic risk scores were associated with a 3.3-fold increased risk. And then when we added the polygenetic risk score to the clinical models, and the prediction power increased from 80% to 94%. And then if this model can be validated in the external population, it could be able to move to the clinic. For example, patients depend on, the physicians could choose their radiotherapy dose based on whether the patients were sensitive or whether they're susceptible to toxicity. And if the patients are susceptible to toxicity, and the clinician might want to use a reduced radiotherapy dose. And another example is a model for predicting recurrence in early stage non-small cell lung cancer. And we have developed a serum microRNA ratio risk score using discovery and validation set, and that can predict recurrence in early stage lung cancer. And the high risk group had a 24-fold increased risk of recurrence, and the median recurrence free time is 37 months. And nearly 40% of the patients developed the recurrence, while the median recurrence free time is more than 60 months for the low risk group. And only 2 out of 42 patients developed the recurrence. And this microRNA signature, and when we incorporate into the risk prediction models, and we found this signature can improve the risk prediction from 64%, based on the clinical variables, and improved to 89%. And therefore, if early stage lung cancer patients, if we predict that these patients has a high probability of developing recurrence, and these patients, we might want to suggest, the patients and should be after the surgery, and they should also might receive adjuvant chemotherapy or immunotherapy. And here is another model we generated. It's a risk model to predict the recurrence in breast cancer. And here are the identified risk factor. And as you can see, as the number of risk factors increased, and the recurrence is also increased. And we also found that Black has the highest risk and Hispanic has the lowest risk, and the patients diagnosed with cancer at a younger age had a high recurrence risk than patients diagnosed with cancer at an older age. We also see striking differences in distribution of risk factors by their ethnicity and by breast cancer subtype for HR positive and triple negative subtypes. Therefore, individuals with different risk may make different lifestyle choices or decisions about the possible preventive interventions to reduce their risk or select treatment options to improve clinical outcomes. And therefore, we needed to translate the research discovery into clinical and community applications to predict, prevent, and cure cancer precisely. And our research discoveries could contribute to a precision health clinic by providing these multi-layer services, and that including primary prevention, or for secondary prevention, and for tertiary prevention. And for example, for the lung cancer risk prediction model, and we have created a web-based tool for lung cancer risk prediction. For example, a 60-year-old male with light smoking history, but a positive family history of lung cancer and a low lung function and a normal blood test will have a predict the risk. We can predict the risk and for the next 2 years, 5 years, and 10 years. And now my presentation has completed, and thank you for your attention, and thank you.
Thank you, Professor Wu, for your enlightening speech. I appreciate your lecture and felt as if you are speaking directly to me. So thank you so much. And I'll leave some time here. So if anyone have any questions or comments, you can please ask Professor Wu now.